It is a delight to be able to introduce Dr. Hudson Garrett. Hudson has worked extensively in many aspects relevant to infectious diseases, infection prevention and control, has been a long time proponent of environmental infection control and the many leadership aspects that are important for our response in addressing COVID-19. So we wanted to interrupt in the series that we had planned because of some of these kind of late-breaking events that we've all gotten to know and love, I guess, OSHA at a new level as part of our COVID-19 response. And given then some of the late-breaking activities that have occurred with respect to OSHA and healthcare facilities, not only hospitals, long-term care facilities in particular, that we wanted to make sure that we provided some update for each of you because it will be important for you to know what OSHA is doing, what it means for you in your particular setting, and then begin to develop a targeted strategy. So Dr. Garrett, let me turn it over to you, and for the next 30 minutes, go through and kind of give us an update, get us up to speed on what is happening with OSHA and their targeted enforcement initiative regarding COVID-19.
Awesome. Thank you very much, Dr. Carrico and Dr. Ramirez. So really this week, we're going to talk about this new targeted enforcement initiative from OSHA. And as I think Ruth mentioned, it's a ever evolving topic, right? We have sort of a love-hate relationship within OSHA. And here are my disclosures so that you can see those just for purposes of transparency. And really the objectives for our short time together is I want to talk about what the overall implications for these new targeted enforcement initiatives are, not just for inpatient, but really for all of healthcare and what it could mean in the future. We'll talk a little bit about the overall national emphasis program, and then how can we operationalize some of these things, and many of which we're already doing, which is nice. However, there's going to be some more targeted enforcement activity that we'll talk about. So, one of the questions that I think comes up is why in the world now? And part of this is certainly OSHA has been a little bit late to the game in terms of releasing different initiatives for workplace safety related to COVID-19. Historically, that has sort of been their MO to a degree. If you look at bloodborne pathogens and some of the other standards that have come out, they've been almost retroactive. And so in many cases, this is not abnormal. However, the way in which they're releasing these new standards and guidelines is a little bit different through this national emphasis program, which we'll talk about here in a second. You're going to also notice that there's some specific timing associated with this that is term limited. As the national emergency comes to an end with COVID-19, this will also limit some of OSHA's capacities, and they'll really be moving into more of a long-term strategic goal of how do we create sort of a plan for healthcare in general that'll be a formal rule, which will require public comment. So I thought it would make sense just to look at sort of the month to date as far as OSHA inspection data. This is going to be data that is specific to COVID-19 enforcement. So these are going to be for hospitals and skilled nursing facilities. You can sort of see that they report it by week, and you can see the total number of complaints. The total number that are closed means that they were closed without any type of issue or any citation, but those that were referred are ones that actually had merit to them. And so those would go on to additional inspection activity as well as potential enforcement and punitive activity as well. So you can see the overall numbers are pretty high. That being said, a lot of this activity is going to take place at the state. Remember that not every state is going to actually be a federal OSHA state. And so some states may actually have their own enforcement activity, but overall you can see a fairly large sample size here just for the month of March. And they actually have this data going back for about 2 years now, looking at the COVID-19 inspection. One of the other areas that I thought was very fascinating was, and I've included the hyperlink here, so we'll make the slides available to you. And this was just actually a snapshot that I took as of last night. And you'll see the total number of penalties there, over $4 million. And I just ran just a very simple report and looked at the establishment name, sort of where it was located. And then on the right is, to me, the actual most important, which is our standards cited. You'll notice that a lot of these standards, if you're not familiar with the OSHA standards, will fall under what we call the general duty clause. The general duty clause in my mind is almost like number 10 on your actual job description, where it says other jobs is assigned by supervisor. In the OSHA world, this sort of general duty clause is specific to say you should know that you should do this because it's the common sense thing to do. It's not a specific reference back to any standard. So, normally when this is used, that means that OSHA has found something that is a violation, but they can't tie it back to a specific existing standard in the law. And so it's almost a catch-all. So think about that at like fever of unknown origin, just as a diagnosis, very similar here. But you'll notice that about half of these are the VA, and the other half are actually in long-term care. And so this is what we're seeing more and more of. And if I went through the entire report last night, and you'll see hospital data in there as well, but it gives us an idea of not only geography-wise that this is a widespread issue, but when you look at the number of citations in the standards cited, you can see it's fairly widespread. So part of this has led to this expanded scope that OSHA has. And this actual document was just released, which is why I think Dr. Ramirez says there was an adjustment made to the Grand Round schedule, because we wanted to be timely in bringing some of this information. Now, this is a term limited time period, so this is going to end June 9th of this year. That being said, there's always the possibility that they could do an additional 90-day extension. And really the target area here is looking at acute care hospitals as well as long-term care. And it's going to be specifically for facilities that take care of COVID-19 patients, which is really going to be everybody. So it's pretty rare, even in long-term care, that you'll see one that will not accept a COVID-19 patient. Now, the way that they're classifying this, just for purposes of context, is they're using the NACS codes, which are going to really identify the different types of healthcare facilities. And that's what the surveyors are actually using to identify the facility targets. So these are the actual codes that they're using. You'll see that it's going to include general medical and surgical hospitals, psych and substance abuse facilities, nursing homes, as well as assisted living. I would particularly call your attention to assisted living because this has not been an area of enforcement activity in the past. This has really been an area that most states, as well as federal OSHA surveyors, have actually stayed away from. But we realize that the risk of comorbidities and other potential impacts of COVID-19 in those facilities, as well as skilled nursing, are really the highest. And so it makes sense that this is going to be sort of their list of targets. Now, as part of the actual inspection criteria, they're really looking at sort of a couple different buckets. One is if you're a facility that already had violations, fair game, right? You're going to be on that top list, that top tier of where these OSHA inspectors should spend their time. The sort of second area is they're going to try to figure out whether or not the employer, right? Remember that OSHA exists to protect the employee, has implemented some type of robust plan from an infection prevention standpoint. That includes things like PPE readiness, fit testing, do they have a response plan? What type of infection control measures do they have, as an example? The sort of third bucket they're going to look at is, are we actually measuring to see if it's working? We all know that we can collect data, but if we do nothing with the data, it's useless. And so what they're looking for here is a good, effort. It doesn't have to be perfect, but a good effort that is going to specifically look at things like vaccination status, right? And particularly in long-term care, where we know we've got, higher mortality and morbidity. We've obviously got, a different population of healthcare providers, and certainly a lot of hands-on care. They're going to specifically drill into vaccination status to make sure that there's a process in place for doing that. Now, of course, some of the primary vaccination enforcement is going to come from CMS, but OSHA is definitely looking for this as well. And then lastly, they're going to look at the facility's injury logs. Were there any reportables? And we'll talk about what those reports are here in just a minute. And I have included, again, the hyperlink here directly to the OSHA enforcement document, should you want to do that. And there's also going to be an ebook that I've made available following today's presentation as well. So the sort of fifth area is PPE, right? No surprise. We want to make sure that staff have access to it, that it's appropriately fit tested, that they're using it correctly. One of my favorite examples was a picture of an OSHA surveyor looking at a nurse in long-term care, and she was in a COVID area, and she had a surgical mask underneath her N95 respirator. Of course, we know that's not how it's designed to be used. No one had corrected her, and they were cited for that. So that's definitely something that we want to be cognizant of as we look at this particular enforcement activity. One of the other areas is that what we call a limited records review. And really what they're centering this around for purposes of this targeted enforcement is all about respiratory protection. So they're looking for, again, was that individual provided with PPE? Were they properly, medically evaluated? Were they fit tested? Have they, do they know how to do a user seal check? All those types of things. And then lastly, they're going to do a walk around, right? And again, this is a focused walk around. This is not a general OSHA inspection. However, of course, if they saw something that was of immediate jeopardy, they would be entitled to take action for that. But they're really looking primarily for where are the biggest sources of risk that might exist within hospitals, skilled nursing, as well as assisted living that might cause transmission. Places like dining rooms or other communal areas where you're going to have sort of that congregation of both staff members, but also the patient themselves. And so part of this is going to be pulled directly from the OSHA records. So, if you're not familiar with the reporting, this is primarily handled by your occupational health team, but the OSHA 300 and 300A log, and then the 301. And really, these are designed to capture sort of reportable incidents that OSHA deems must be reported to the agency within a specific time frame. Now, what I think is interesting here and important to call out is that they're actually looking back through the very beginning of the pandemic. So they can certainly go back to 2020. It's almost like a tax audit. They can go back several years. And they're really trying to identify where there are workplace related cases of COVID-19. And certainly that can be very difficult to prove or disprove. And really what they're looking for specifically here is a total of 15% of all of their inspections will be in this category. Right. And so again, they're going to categorize, folks that have already had previous violations first, and then individuals where there's obviously complaints that have come in or potentially random inspections based on other enforcement activity. So that really builds us right into this slide, which is about who is going to get picked and how is that going to be prioritized. For perspective, there's roughly about 3,000, I believe, OSHA inspectors in the entire United States. We know that there's thousands and thousands of healthcare facilities across our country. And so it would be impossible for an OSHA inspector to inspect any of those, at one single time. Even in a state, you may have one or two OSHA inspectors that cover large areas. And so they're going to use this prioritization to say, where should we actually spend the majority of our time? Right. And as I mentioned before, if they had a previous citation or a hazard alert letter that was specific to COVID, they're going to pick those first. They're going to also be looking for follow-up surveys as well as other activities that might be coming in through anonymous reports is another one. Certainly they can be called in by the state or CDC or other public health agencies and workers. Keep in mind that OSHA does allow you to anonymously report workplace safety concerns on their website or by calling their 800 number. And so this can create sort of that random sampling that we talked about where they may go in and actually inspect those facilities or do follow-up activities, very similar to what we would do with normal accreditation activities. So in this walk around, as I mentioned, they're going to be looking for a couple of big elements. Certainly, and first and foremost is the respiratory protection program, right? Are we fit testing that medical evaluation? Do we have proper training and competency of those individuals? And do we actually have the ability to demonstrate that? Right? Remember that training alone does not equate to competency. And so we spend so much time and money in healthcare training, but we spend very, very little time, in my opinion, actually validating competency for the role that we're actually trying to, train for. The sort of second area is good documentation principles, right? What if you have one single respirator and that respirator becomes unavailable due to supply chain challenges? Of course, that would never happen. I'm being sarcastic, of course, because it's happened many times during the last 2 years. And so having redundancy in your supply chain is another thing they're looking for, right? And you can also look at things like reusable respirators, like an elastomeric as an example. Some facilities, for example, in COVID areas have PAPRs. It just really depends on sort of the financial resources of that particular healthcare facility. Now, sort of the third bucket, I think is a little bit more challenging, right? And it's about screening. And so we have certainly seen a decrease across the country and really globally in overall screening for COVID-19. If you think about it, at the very beginning of the pandemic, it was very temperature-based, very, very few symptoms. And then as we expanded that symptomology profile of that average COVID-19 patient, we know that the screening changed and evolved. And in reality, there's a lot of benefit to doing screening, but not just a temperature. Do you have diarrhea or vomiting? Have you been around anyone that's been sick lately? Do you have a fever as an example, right? All of these are important questions that we want to ask, but we want to find documentation and evidence that there is good screening in place. One of the best ways to do that is to screen the inspector when they come in, right? Make sure that they don't, just because they have official credentials and they walk through your door doesn't mean that they get to exempt screening. And I have seen OSHA inspectors repeatedly cite people for letting the OSHA inspector in immediately. You have every right and the responsibility to stop that inspector, whoever it may be, put them through your normal screening process prior to giving entry to the building. And then the last area is, of course, our moving target, right? What should we really be doing with face mask and face coverings and mask and all of that type of stuff? And certainly recently, CDC has released additional guidance that is more community-based, based on transmission rates, healthcare resources, and overall availability. That is a little bit more helpful, I think, in determining where the largest populations of risk are. But most of us in healthcare are continuing to wear some type of mask when providing clinical care, for sure. Now, there are things, right, that we can control, and there's things that we can't, right? The things that we can control, the bucket that we have the ability to drive success with, is we can control our training, how we assess competency, certainly our viewpoint on quality improvement. And any devices that we use, we can also monitor those for overall effectiveness within our patient population. But there's also a bucket on the other side of the coin that I can't control. Right? I can't control if a patient has obesity. I can't control if a patient, has chronic health conditions that they're unwilling to treat. I can't control if somebody has sort of an unanticipated occupational exposure, right? OSHA is all about anticipation and sort of a risk analysis. For example, if you have a brand new employee, and that employee is sort of rated at the very lowest risk profile, meaning they should never have any type of anticipated exposure to blood, but you still provide them some bloodborne pathogens training, but maybe you don't offer them the hepatitis B vaccine series because it's not indicated, and yet they have some type of exposure. We can still treat that, right? And we can still do that, but we have to be careful about putting everybody in the same bucket because we know that roles are different. Certainly a CNA and a long-term care facility is going to have a lot of direct exposure. You may have other people in the facility that don't. So we want to treat everybody sort of individually from that perspective. Now, you ask OSHA the question of, well, what is causing this? They're saying it's a safety issue, right? Because their whole existence is around safety within the occupational space. They're not concerned with the employer. They're concerned specifically with the employee. Now, one of the data points that I think would be very helpful, and we can all agree to this, is to know the total number of healthcare providers that have actually contracted COVID-19 in the workplace due to occupational transmission. And we really don't have a good handle on the true sort of impact and burden of that number. I think that's a very important data element that's missing to help us sort of understand the true burden of illness within healthcare, but also the overall risk to healthcare providers that might be present there. And this sort of leads us into this conversation of risk management, right? Risk management creates opportunities for risk mitigation. And so if we think about all of these different challenges, all the silos, all the disciplines, the different types of patients and residents that we care for, it can create sort of a difficult scenario, right? Where we have this very complex machine that we're trying to manage. And so OSHA's intent here is to simplify this and say, let's do good common sense infection control measures. Let's make sure that we properly fit, test, and provide PPE. And let's also assess for competency, right? Those are three big buckets that certainly make a difference here. And the way that my brain works, I try to keep things pretty simplistic. And I call this the 3 Ps: people, process, and products, in that order, right? If I focus on individuals and I get my folks that are at the front lines taking care of the patients, and I empower them, I give them good stewardship resources, I make sure they're really well qualified for their role, and there's good executive support and leadership, then that's going to make a huge difference, because it's going to strengthen my overall infection prevention program. It's going to reduce my risk for occupational transmission, which is relevant to today's topic, but it's also going to give me a better competence in my overall process. The thing that scared me about COVID was, frankly, not really the disease as much as it was our overall response to the disease. The things like PPE and supply chain challenges. Certainly now we're experiencing staffing challenges unlike any other. And those are the things that frankly keep me up at night. How do we move those needles forward to make sure we have the right person taking care of the right patient, doing the right task with the right support system around them to make sure that they're actually successful? And that really leads us into the second P, which is process, right? If we don't ever assess for, are we doing well? Do we have opportunities for improvement? And never use that approach, it can be very challenging, right? Because we're never able to say, how do we go from our current baseline to that next level? How do we raise the bar, if we will, for infection prevention? And I've really, from my vocabulary, removed the term patient safety. I rarely will use that now. I talk about healthcare safety, because without good quality workforce folks at the front lines, nurses and clinicians and other providers, we can't deliver care. And so we have to shift our focus away from just this sort of singular approach to patient safety, and think about this in the broader term as it relates to a process to protect all of the workforce within healthcare. And part of this can be dictated by good syndromic surveillance, where I get like an instant alert, some type of precipitating factor that says there's a potential problem here. And I think about this like tornado sirens. Unfortunately, we don't have anywhere I live in my community, but down the street they do. And so I can still barely hear it. But remember that warning sign may go off 5 minutes, 10 minutes, or it may not go off at all. And so the more data validation that we have that tells us in real time, there's a potential red flag here, whether it's a lot of workers out with similar illnesses, or we have several residents that have had to been transferred to the hospital from a long-term care facility due to COVID. This is all helpful data for us to understand. And then lastly, the last P is products. Right. And really, when I think about products, it's not a specific thing as much as it's what do we use to daily take care of our patients? And then also what services may go with that. So you may have particular brands or product solutions that you use, but I need to have confidence that my supply chain can keep up with my need. And I'm not sure that we all have that level of confidence for right or wrong, because it's just been very challenging. And that's why, I've moved to things like an elastomeric respirator where I have guaranteed respiratory protection, just as an example, but we're going to have to make adjustments. CDC does have a good forecasting tool that looks at PPE that I would highly encourage you to check out. If you've not seen that before, it's available free on their website. And then think about, what can I do as sort of plan A when everything is going well? What can I do to sort of plan B, or that contingency mode, as CDC refers to it, where we're starting to experience supply chain disruptions? And then what do I do when I get into that really bad spot of crisis mode, or crisis, management, where I'm not getting the products at all? I may have to improvise or reuse some of these devices that are out there. And this leads us really well into this hierarchy of controls. I use this graphic almost every day because it helps me think both visually as well as when I am being tactical in an approach to what's going to really give me my biggest bang for my buck and my biggest return on investment. For example, if we look at the very bottom of this pyramid, you'll see that PPE is listed. You'll notice to the left of there that ironically it says it's the least effective thing that we can do. Versus on the very top right, you'll see that we've got the elimination, which is our most effective. Now, we've used a combination of these approaches, right? Initially, we used tons of PPE and we continue to do so. Then we thought about, well, maybe if we put up plexiglass or some of the different barriers as an engineering control, we might isolate people. And yet there's been very limited data that shows that that actually is very helpful in stopping transmission. And if we could get to a point of elimination, let's say we had a vaccine that was 99 or 100% effective at eliminating COVID-19 infection, that would certainly give us a big arrow in our quiver that we could fire at this thing all the time. But what we find with most things in infection control is that it's a combination of all of these, right? We will use all the different resources that we have. We'll deploy them in a way that hopefully makes sense and is rooted in the evidence, and also apply the evidence to our specific practice situation. Not every CDC guideline, for example, gives specific recommendations for long-term care. Yet we know that the acuity in long-term care, as well as the risk profile, is pretty high. And so it's important that we try to customize where we can to ensure that we're meeting the needs of our clinicians. And part of this is sort of an internal gap analysis to say, what is it that we think is going on, right? What are we seeing with our own two eyes? It always goes back to the old adage of treat the patient, not the monitor, right? If the patient is in asystole on the monitor, but you look at the patient, they're able to talk to you, they're clearly not in asystole. Yet our equipment is telling us something different. And so the literature may tell one story, but we want to make sure we adapt the best practices to our specific practice settings and understand that there is going to be inherent risk in the equation, but there are ways for us to mitigate that, right? And that's really going to help us, sort of respond to some of these nuances. Now, one of the big things, and I've had this conversation actually with Dr. Carrico several times, is how in the world do you keep up with all the changing guidance? I know that I, every day go and sort of do a screenshot of the CDC guidance just for my own records to know what was there when we began versus what changed when. And that's been a helpful activity, but it got to be overwhelming. And so it's something that most people can't do every day. But as this guidance changes, one of the best things to do is to sign up for the CDC's weekly Division of Healthcare Quality Promotion COVID update. And so that is a great tool and resource that will help you stay up to date on some of the ever-changing guidance that comes out there. So part of this is, and I use this graphic on purpose, we have sort of two doors to go down, right? Do we go down door A, which is maintain status quo, almost what I call the definition of insanity, to repeat what we've been doing over and over again, expecting something different to happen? Or do we take a little bit of a leap of faith and open door B and actually change our practice, be more agile as a profession, be more responsive, really focus and hone in on protecting our workforce? That's going to do two things. It's going to physically protect them from the risk of infection, but equally as important, it's going to help build back up their resilience. And we know that we are hemorrhaging healthcare providers across the country, and we want to do everything in our power to retain our best people so that we've got the right folks to take care of our patients. And this sort of, leads nicely into this topic of what is my goal, right? What should our approach to safety actually be? Is it total elimination? Well, that sounds great, but is that practical? Can we prevent? Absolutely. Certainly healthcare associated infections, we have good evidence to prevent, almost all of those, right? It's a matter of the human factors perspective here. And how can we mitigate that risk of not only permanent harm, but also general injury that might take place to our staff? So there are some applicable OSHA regulations. Again, I've included the web link here in case you want to go look at any of these, but these are pretty self-explanatory, right? The one I again want to call your attention to is the general duty clause. Remember that if OSHA can't find another spot to cite you and they still want to cite you, that's where they're going to go. So it is a catch-all citation category that allows them to say, you should have known what to do. It's a common sense thing, and any prudent workplace would have taken these steps. And I'll just give you an example. Let's say that hypothetically you provided no hand sanitizers. It was not actually in the regulation. They could then cite you under the general duty clause based on CDC guidance to say you should have done that, even though it wasn't explicitly listed out in the actual regulation. And so this is something that they do quite frequently because the regulation itself can take some time to actually change, because it does have to go through the legal process from that perspective. And then finally, who is this going to impact? Right? One of the beauties of healthcare is that you have all the different disciplines that bring something unique to the table. Not only do they bring a unique skill set, but equally so, they bring a unique lens. For example, if you're talking to somebody who is a frontline environmental services worker, they have the perspective on what the patient's thinking. What are they saying when they're in the room? What are they most worried about? That is probably very different than a physician, as an example, or a pharmacist who is not going to have that level of interaction or intimacy with that particular patient. Other functions, like the patient safety officer, may be a little bit more removed from general patient care, but as an enterprise, they have a big role, right, in managing and mitigating some of the safety risk that's associated with that. And we'll all, definitely see an increased focus of occupational health, I hope, whether that's an in-house activity or if you contract that out. Occupational health's not going away. As a matter of fact, I think we need to put more emphasis in this. And I would encourage us to think outside of the basic physical medical needs, but really also address any of the psychological needs. As we look at some of the stats coming out on suicide and burnout, and general stress management and anxiety in healthcare providers, it's astounding, the number. And so we've got a pretty strong opportunity there that we need to take advantage of in trying to address some of those underlying issues. So what the future holds long-term, I can pretty much guarantee that there will be a permanent standard that will come out from OSHA. They've pretty explicitly said that. The timing on that is what's more up in the air. As they do normal standard development, they will publish that for public comment. They usually do that for anywhere from 30 to 90 days. And then you can go onto the Federal Register and actually provide that comment. I would encourage you to go do that because that final rule, I would anticipate, will be coming sometime later this year. One of the other things that I'd mentioned a few times by design was that we need to kick sort of this patient safety term to the curb and really replace it with healthcare safety. so that I'm taking care of my patients, my visitors, my staff members, my contractors, my vendors, whoever may be involved in that particular delivery of care. And a lot of this goes back to operationalizing and hardwiring the general infection control core practices. And that's a whole different topic that we could spend an hour on. But I really feel very confidently that if you do those core practices like wash your hands, don't reuse needles and syringes, wear PPE appropriately, et cetera, you're going to see a significant reduction in not only the risk profile, but also the general occupational transmission that might take place, or unfortunately transmission to the patients and the residents that we serve. So with that, I'll sort of stop and see what questions you have. So at this point, Dr. Carrico, I'll turn it back over to you. And I've also included my contact information in case there's any additional resources I can make available, but I did provide an ebook, and they'll also publish the slides as well to those that attended today.
But thank you very much, Hudson. And I think this brings up several kind of reminders or recaps. In the past, I think we have somewhat separated the responsibilities with respect to OSHA compliance and infection control, and largely left them in the occupational employee health bucket. But COVID-19 certainly changed that. And I think this emergency, or this initiative from OSHA really demonstrates that infection control has to be directly involved with this. If we think about reducing the workplace hazards, then we're thinking about reducing opportunities for infection to occur, recognized or unrecognized, in the patient population as well as in the employee population. So one point I think maybe as we look to change the perspective among the infection prevention world, what might be a couple of take-home points for the infection prevention community to use when they think about what their responsibility may be in this, both this 90-day standard and then what we may be forecasting beyond 90 days.
Yeah, I think that's an important point. And, going back to that definition of insanity, if we still operate the same way we did in 2019 today, that's our insaneness, right? We have to evolve, I think, to your point, as not only a profession, but also as a multidisciplinary effort to protect all that are involved in both the delivery and receipt of healthcare. So, the core practices, as I mentioned, are a great starting point. I think it gives everyone a blueprint of, if I focus on these sort of things, right, and I put a lot of attention units behind that, my impact will be high. If I operationalize, hardwire, and assess for those, whether it's through competency, visualization, rounding, those are all going to be really important steps that will help not only the infection preventionists, but remember, the IP is really a facilitator. They're sort of that internal expert consultant, but they can't do everything. And so the more people that we can get on board as champions at the front lines, I think is going to be helpful. And my sort of last point is, let's not make everything about COVID. COVID sort of was a precipitator to having this conversation, I think. And I think there's always great learning that can take place through outbreaks and certainly pandemics. But if we don't take advantage of that, then shame on us. There have been so many lessons learned. I think I have about 4 or 5 pages of things that I've written down over the last 2 years of, hey, this needs to change. And every day I add to that. And so we need to be open, willing, and able to be agile. And a lot of times we're not very adaptable as a profession in many instances. And so maybe engage human factors engineers, certainly change management experts in your healthcare quality department, and other professionals that are really adept at moving the needle. I think that's going to be a helpful sort of coaching resource that will be beneficial to all.
Great, thank you. I want to make sure to remind people, if you have questions, you can certainly unmute yourself if you would prefer to put something in the chat. So we try to take advantage of another couple of minutes for any specific questions. As Dr. Garrett mentioned, we'll record this and also put it on the YouTube channel that will house all of the Norton Infectious Diseases Grand Rounds series. And then I'll make sure to send this out to all of the participants, so you'll have access to that as well. So when we think about, just at our last few minutes from a couple of take-home messages. What are some immediate actions that the infection prevention and control community need to take? What are some, on their to-do list, on their checklist? What are some specific things that need to be done in preparation for, in case somebody is, the lucky winner of an OSHA visit, or in preparation in case they win a visit and feel like they were unprepared, or didn't, quote, meet the criteria, or didn't deserve one of the visits. What are some things that can be done to begin to work on preparation?
Yeah, I think that's an important question. I mean, number one is know your data, right? You need to know what's in your OSHA logs. Your OSHA logs may differ from what you've been provided from occupational health. And so, or from, infection prevention. So regardless of what your role is, be on the same page as far as what access to data does OSHA have. And again, they're going to look at those OSHA documents specifically. So your 300 and your 301 logs, that's going to also give you sort of an idea of, was there true occupational transmission? And if you've got a lot of that, then you're absolutely going to be a target, and you need to know that up front. But most people will not have significant red flags within the logs. Where they're going to get you is sort of your documentation, your training, and your assessment of progress. It is totally fine to tell an OSHA inspector, hey, I just actually did an inspection on this morning. Here are my findings. This was not in line with what our expectations are and what the training was. And here's my risk mitigation program. And I think in healthcare, we're very hesitant. And our legal departments will certainly tell us, don't volunteer anything to a surveyor. And I have a little bit of a different approach. I think that if you are taking action currently to improve that area, share that. I found in my experience that actually is well received. They appreciate the candidness and the transparency. And again, it also demonstrates your commitment to that ongoing continuous quality improvement, which is what every patient deserves and every staff member deserves. And then I think lastly is, really, again, focusing on those core practices. If you hardwire those, assess for those, you're going to prevent not only COVID transmission, but you're going to have a wide ranging impact on other nosocomial type issues that we might see in healthcare. The complexity of our patients, the acuity, the amount of equipment, sort of the movement of patients throughout healthcare is just mind-boggling. And so everything that we can do to improve our odds, I think will have a positive impact on overall patient care and reduction of risk.
So I know we've spent a lot of time, I know particularly with the state recently talking about sharing information across settings. Mm-hmm. We don't have a good way of doing that. I know this has been something that everybody's been working on for a number of years, but it just reminds us that, we have the responsibility to share information about, COVID, about other types of infections that may impact other settings. So as we move patients, figuring out how we can work effectively together to find out who to share, how to share that information. But, ultimately, not only does it protect the patients, it protects the healthcare workers as well. So thank you for this information. Did Dr. Ramirez, you want to close out our series?
Well, I want to mention something from Hudson put there, the infectious disease physician. I want to mention something that I think that all this is very important. And I want to mention that when Hudson said, have we had COVID-19 transmission in our hospital? I want to just estimate that probably there is not a single hospital in the United States that a healthcare personnel didn't acquire COVID from the hospital. Right. Remember that at the beginning, we didn't have testing.
Right.
When we have testing, we were allowed to test only if you travel from China, when the ICUs in Italy were full of COVID. Then we were allowed to test only the person with respiratory problems. And we all know friends that develop COVID by taking care of patients. Right. And we know here in Kentucky, nurses, physicians that died of COVID. And we know that this was not COVID at home, was COVID related to a hospital. Then this is coming today because for the first time since we practice medicine, for the first time since we are in healthcare, it's the first time that you were able to go to the hospital and acquire something in the hospital that can kill you. Because before COVID, we can acquire tuberculosis in the hospital from a patient that we failed with respiratory protection. But okay, it's fine. I take 9 months of a pill and I'm going to be cured. Was never the idea that I'm going to go and do my work at the hospital. I have the risk to die. And this is why so many healthcare workers decided to stop working in healthcare. Then I think that we need to tackle this with the understanding that at the beginning it was a new disease, but there was no question that almost we all have people that acquired COVID just because of working in healthcare. Now we have, in these 2 years, we improved so much that I don't think that we don't get this problem anymore. We have so many implementation. We don't, but it's, I think that we need to recognize that OSHA is coming with something that probably is going to be here to stay, because we don't want for this to happen again. We don't want for healthcare workers to go to a hospital, have a risk of dying, because tomorrow we have a new pandemic and we go through the same mistakes.
Yeah, I would agree, and it's interesting that you make that point, because if you look at the COVID net data from CDC, I've had comments made to me that, well, that data is very low. It looks like there's very few healthcare workers, and I totally agree with you, Dr. Ramirez, that not only did we not test, but in many instances, those workers just didn't come back to work, or maybe they had symptomology that we didn't think was consistent with COVID-19, and so we never thought to capture those individuals. So I think, when we look at overall resiliency and the workforce, it makes a huge difference. And so, while I'm appreciative that OSHA brought some of this to light, it was unfortunately very late in the game, I think, to your point. So I would agree, we've got a lot of learnings, and I'm hopeful that on a federal and state and local level, we'll start to see some debriefing activities that bring these issues to light so that we can talk about them in the open and make sure, to your point, that we are doing everything in our power to, again, ensure the safety for all involved in healthcare, not only with delivery, but also with receipt, because we've historically so focused on the patients, but really not focused so much on us.
Excellent. Well, thank you very much for leading our discussion today, and we look forward to continuing our infectious diseases series. And I think our topic for next Wednesday, March 23rd, will be case control studies. Thomas Chandler will be leading that discussion. This will be, again, important for infection prevention and control, because we'll have many of the basic discussions about the epidemiology and the epidemiologic tools we use for a variety of evaluations in our healthcare settings. So thank you very much, again, everyone, for joining. And Dr. Ramirez, any closing remarks?
No, thank you. Thank you for everybody for attendance. Thank you.
Thank you very much.
Thank you, Hudson. This was excellent as always. Thank you.
Thanks for the invitation, Dr. Ramirez.